Good morning. Today we will be discussing the topic atherosclerosis. The topic will be discussed under the following headings: definition, etiology, pathogenesis, morphological features, and clinical features. Coming to the definition, atherosclerosis is a thickening and hardening of large and medium-sized muscular arteries, primarily due to involvement of tunica intima, and is characterized by fibrofatty plaques or atheromas. It is the most common and most important arterial disease, and it most commonly affects aorta, coronaries, and cerebral arteries. Coming to the etiology, atherosclerosis can be caused by loads of risk factors, which can be classified into major risk factors and emerging risk factors. Major risk factors can again be divided into modifiable and constitutional. Modifiable risk factors include dyslipidemia, hypertension, diabetes mellitus, and smoking. As the name indicates, these risk factors can be modified by changing our lifestyle or by drug intake. Constitutional risk factors cannot be modified, and it includes age of the patient, sex, genetic factors, familial and racial factors. Emerging risk factors are the risk factors which also contribute to the development of atherosclerosis, and these include environmental influences, obesity, influence of hormones, physical inactivity, stressful lifestyle, homocystinuria, alcohol, prothrombotic factors, infections, and C-reactive proteins. Now we will be discussing the modifiable major risk factors one by one. So these risk factors, as I have told earlier, can be modified by lifestyle or by therapy. First one is dyslipidemias. Hypercholesterolemia has directly proportionate relationship with atherosclerosis and ischemic heart disease, as we all know. Among these, LDL cholesterol or low density cholesterol play an important role in development of atherosclerosis. High cholesterol levels are associated with the dietary intake of saturated fat, trans fat, and high calories, while polyunsaturated fats and omega-3 fatty acids have protective role against development of hypercholesterolemia or dyslipidemia, which can lead to atherosclerosis. There is also an entity called familial hypercholesterolemia, which is an autosomal codominant disorder with mutation of LDL receptor gene with elevated LDL and normal triglycerides. This condition is associated with occurrence of xanthomas and premature coronary artery disease. The management of dyslipidemia is directed at lowering the low-density lipoproteins and total cholesterol and raising high-density lipoprotein by weight loss. High-density lipoproteins has a protective role against the development of atherosclerosis and ischemic heart disease. Next is hypertension. Hypertension is a risk factor for all clinical manifestations of atherosclerosis. Here, hypertension causes mechanical injury to the arterial wall due to increased blood pressure, which can trigger the formation of atherosclerosis. Third one is smoking. The extent and severity of atherosclerosis is more in smokers compared to non-smokers. Smoking tends to reduce the level of high-density cholesterol. It will derange the coagulation system, cause accumulation of carbon monoxide in circulation leading to hypoxia, All these favor the development of atherosclerosis. The fourth one is diabetes mellitus. Atherosclerosis is more common and develop in early age in patients with diabetes mellitus, both type 1 and type 2. Type 2 diabetes mellitus is associated with metabolic or insulin resistant syndrome and diabetic dyslipidemia. Diabetes mellitus causes endothelial dysfunction, increased aggregation of platelets, increase in LDL and decreased HDL. All these can contribute to the development of atherosclerosis. Now coming to the constitutional risk factors which cannot be modified by us. So these are non-modifiable major risk factors. First one is age. As we all know, atherosclerosis is an age-related disease. Even though the early lesion may be present from the childhood, fully developed atheromatous plaques appear in 4 decades of life or beyond. Coming to the sex, incidence of severity of atherosclerosis is more in men than in women. Coming to the genetic factors, hereditary derangement of lipoprotein metabolism can lead to high blood lipid level and familial hypercholesterolemia, which can promote the development of atherosclerosis. Now coming to familial and racial factors, familial risk of atherosclerosis is related to other risk factors like diabetes mellitus, hypertension, and hyperlipoproteinemia or dyslipidemia, which runs in families. Also, some racial groups like white people are more prone to development of atherosclerosis compared to the black race. Coming to the emerging risk factors. Emerging risk factors are not major risk factors which can lead to atherosclerosis, but they also contribute to the development of atherosclerosis. These include environmental influences. It is said that there is high incidence of atherosclerosis in developed countries compared to developing countries. Metabolic syndrome, which includes central obesity, glucose intolerance, insulin resistance, dyslipidemia, and hypertension, has got a major role or can contribute to the development of atherosclerosis. Exogenous hormones or endogenous estrogen deficiency can also lead to atherosclerosis. Likewise, physical inactivity and lack of exercise, a stressful lifestyle, hypercystinemia, that is, which occurs due to elevated serum homocysteine level from low folate and vitamin B12 levels, can contribute to the development of atherosclerosis. Also, homocystinuria, increase in prothrombotic factors and elevated fibrinogen, certain infections like chlamydia pneumoniae, herpes virus, and CMV infection, as well as elevated C-reactive proteins and acute phase reactant can lead to the or can contribute to the development of atherosclerosis, and these comes under the emerging risk factors. Now coming to the pathogenesis of atherosclerosis. Atherosclerosis, the development of atherosclerosis, it is a multifactorial process. So many factors are involved in the development of atherosclerosis. Earlier, 2 theories were proposed to explain the development of atherosclerosis. These included encydation hypothesis or lipid theory and encrustation hypothesis and thrombogenic theory. According to encydation hypothesis, atherosclerosis is a proliferation of intimal cells resulting from increased imbibing of lipid from blood. And encrustation hypothesis stated that atheroma represented a form of encrustation on arterial wall from components in the blood forming thrombi composed of platelet, fibrin, and leukocytes. Currently, pathogenesis of atherosclerosis is explained by following theories. One is reaction to injury hypothesis, and another one is monoclonal theory. Reaction to injury hypothesis The original theory stated that the initial event in atherogenesis was considered to be endothelial injury followed by smooth muscle lesion. Later, this theory was modified as the initial event is lipoprotein entry into the intima followed by lipid accumulation in macrophages. According to this theory, the key factors which are involved in atherogenesis are endothelial injury of the vessels, intimal smooth muscle proliferation, role of blood monocytes, dyslipidemia, and thrombosis. Coming to endothelial injury. Endothelial injury is the initial triggering event in the development of lesions in atherosclerosis. The causes of endothelial injury include hemodynamic forces, chronic dyslipidemia, mechanical trauma, immunological and chemical mechanisms, homocysteine, circulating toxins, viruses, hypoxia, carbon monoxide, and tobacco. So we can see that all the risk factors which we have discussed earlier can contribute to endothelial injury, which will trigger atherosclerosis in large and medium-sized arteries. Next is intimal smooth muscle cell proliferation. Endothelial injury causes platelet adhesion, activation, and aggregation, and infiltration by inflammatory cells. The proliferation of intimal smooth muscles and extracellular matrix is stimulated by various factors like cytokines like interleukin 1, tumor necrosis factor alpha, which causes synthesis of growth factors. Other growth factors like PDGF or platelet-derived growth factor and fibroblast growth factor causes proliferation and migration of smooth muscles. Also, TGF-beta and interferon gamma regulate synthesis of collagen by smooth muscle cells. Other biomolecules like nitric oxide and endothelin also causes smooth muscle proliferation. Next is the role of blood monocytes. LDL appears in the cytoplasm of monocytes, which turns it into form cells. Plasma LDL, on entering intima, undergoes oxidation. This oxidized LDL has the following functions. First of all, it will attract, proliferate, immobilize, and activate monocyte, as well as it is taken up by the scavenger receptor on the monocytes to turn into lipid-laden form cells. It also causes apoptosis of form cells, which release lipid to form lipid core in the plaques or atheromatous plaques. In the endothelium, this oxidized LDL is toxic and it can cause endothelial injury. So this shows how the oxidized LDL can affect the blood monocyte and the endothelium. It is cytotoxic to endothelium while it causes proliferation, immobilization, and activation of monocytes, as well as it gets into the monocytes to form cells, which form a main bulk in the atheromatous plaque. Now, role of dyslipidemia. Chronic dyslipidemia causes endothelial injury and endothelial dysfunction. Also, increased LDL promotes formation of form cells, and as we know, the form cells form a main bulk in the formation of atheromatous plaque, while LDL has anti-atherogenic effects. Thrombosis. When endothelial injury happens, it exposes subendothelial connective tissue, which will contribute to the formation of thrombus. The exposed endothelial connective tissue causes platelet aggregation, which in turn will lead to smooth muscle proliferation and formation of form cells, and later it will lead to the formation of atheromatous plaques, which enlarges by attaching fibrin from the blood. Next hypothesis is monoclonal hypothesis. It is somewhat simple. It states that the proliferation of smooth muscles is the primary event, and this proliferation is monoclonal like that in a neoplasm. It is initiated by mutations caused by exogenous chemicals like cigarette smoke and endogenous metabolites like lipoproteins and some viruses. Now coming to the morphological features. The early lesions of atherosclerosis or atheromatous plaques include intimal thickening, fatty streaks, and gelatinous lesions, which will later develop into a fully developed plaque or complicated plaques. Fatty streaks and dots. It occurs in the intima and is the precursor lesion for atheromatous plaques. It begins to form in the first year of life and sometimes get absorbed in older persons. It is prominent in aorta and other major arteries, often on posterior wall. Grossly, it appears as a flat, slightly elevated multiple small yellow dots or elongated streaks. Under microscopy, we can see closely packed form cells, lipid-rich smooth muscle cells, and few lymphocytes under the endothelium. Coming to gelatinous lesion, it is also a precursor lesion of atheromatous plaque. It develops in intima of aorta and major arteries in the first few months of life. It is also a precursor of atheromatous plaque. Grossly, it appears as round or oval, circumscribed gray elevations about 1 centimeter in diameter. Under microscopy, we can see foci of increased ground substance in intima with thinned overlying endothelium. Now coming to the appearance of a fully developed atheromatous plaque. So atheromatous plaque is a fully developed atherosclerotic lesion. It is also called fibrous plaque, fibrofatty plaque, and atheroma. The common sites are abdominal aorta, which is most severely affected, aortic arch, descending thoracic aorta, iliac, femoral, carotid, coronary, and cerebral arteries. Grossly, an atheroma appears as white to yellowish white, 1 to 2 centimeter diameter lesion which is raised on the surface. Cut section shows luminal surface as firm, white fibrous cap and central core composed of yellow to yellowish white, soft porridge-like material. Under the microscope, we can see an outer fibrous cap which is composed of smooth muscle cells, dense connective tissue, and extracellular matrix, and is superficially covered by endothelium. There is a cellular area underneath the fibrous cap which is composed of macrophages, form cells, lymphocytes, and few smooth muscle cells containing lipid. The deeper central core is composed of extracellular lipid, cholesterol cleft, fibrin, necrotic debris, and lipid-laden foamy cells. In older or more advanced lesion, the collagen in the fibrous cap will become dense and hyalinized. The smooth muscles will become atrophic, and there will be fewer form cells. Coming to the complications which can happen in a plaque. The pathological changes occurring in a fully developed plaque include calcification, ulceration, thrombosis, hemorrhage, and aneurysm formation. All these account for the most serious harmful effects of atherosclerosis. Calcification. Calcium salts get deposited in the intima near the necrotic area and lipid too. Ulceration. The fibrous cap may ulcerate and release emboli composed of lipid and debris into the bloodstream, which can traverse the blood and can reach other parts of the body. Thrombosis. Ulcerated plaques and areas of endothelial damage are vulnerable for thrombus formation. The thrombi may embolize or get organized or incorporated into the arterial wall as mural thrombi. Hemorrhage into the plaque. It occurs either from blood in vascular lumen during ulceration or rupture of capillaries vascularizing the atheroma. Fifth complication is aneurysm formation. It occurs due to weakening of arterial wall by atrophy and thinning of media along with the fibrosis and inflammation of adventitia. So this is the picture of a fully developed plaque. We can see the fibrous cap which is lined by the endothelium, the cellular area beneath the fibrous cap, and the deeper core which is composed of lipid pool, foam cells, and cholesterol clefts. This is a complicated plaque which shows areas of calcification. So this is the microscopic appearance. We can see fibrous cap, the cellular area, and the inner core. So this is the picture of a coronary artery which is affected by atheroma. We can see here that the lumen of the artery has decreased substantially. So this is the actual microscopic diagram of an atheroma. We can see the fibrous cap, the cellular area which is composed of foamy cells, and the deeper core which is composed of foamy cells, cholesterol clefts, and lipid pool. Coming to the clinical effects. The clinical effects result from slow luminal narrowing causing ischemia and atrophy, sudden luminal occlusion of the vessel causing infarction and necrosis, propagation of plaque by formation of thrombi and emboli, and formation of aneurysmal dilatation and eventual rupture of the vessel. Depending on the organ affected, in heart, it can cause myocardial infarction and ischemic heart disease. In brain, it can cause chronic ischemic brain damage, cerebral infarction, and stroke. In aorta, it can cause aneurysm formation, thrombosis, and embolism to other organs. In small intestine, it can cause ischemic bowel disease and infarction. In lower extremities, it can cause intermittent claudication and gangrene formation. Now, when we conclude, we know that atherosclerosis is a thickening and hardening of large and medium-sized muscular arteries, primarily due to involvement of tunica intima, and is characterized by fibrofatty plaques or atheromas. The risk factors for the development can be categorized into major risk factors, which include dyslipidemia, hypertension, diabetes mellitus, and smoking. Constitutional risk factors, which include age, sex, hereditary factors, and racial factors, and emerging risk factors. The characteristic lesion in atherosclerosis is an atheromatous plaque, which contains an outer fibrous cap, underlying cellular layer, and deeper core composed of cholesterol. The clinical effects depend on the tissue affected, and these include myocardial infarction, cerebral infarction, and ischemic bowel disease, as well as claudication of limbs. Thank you.